Okay, so welcome everybody. I'm very honored to have to be the scientific director of this nice webinar, where the main objective is to show to the audience what is the new evolution of devices related to the BPO surgical treatment, and to see and try to give some answer about the evolution of the technique from the endourological treatment to the minimal invasive treatment to the micro-invasive treatment, which is the new available device from Elesta with the SoracteLite treatment. So I want to thank all the participants to the event and all the audience, which I know is coming from all over the world, from the United States, from France, from some country in Europe. So thanks to everybody. And I would like to start with my brief introduction and then to move to the single presentation of my colleague. The first introduction is why there are so many options for the treatment of BPO. And this is mainly related to the complexity of the patient. So when we talk about BPO, we have patients that have normally different symptoms. They may have irritative symptoms. They may have obstructive symptoms. They may have only one symptoms or maybe a lot of symptoms with the urgency, frequency, or hesitancy, straining, etc., etc. But also they're different because they present symptoms in different ages. They may have different comorbidities. They may use therapy like antiplatelet or anticoagulants therapy. They may have different prostate volume, which drive the decision in a different way about different surgical treatment available. And also they may have sexual activity or not. They may be younger or and healthier, or they may have older with several difference in terms of sexual activity. So this may drive the decision to go towards the surgical treatment and different surgical treatment. But all these parameters that I have already shown are related to the patient and just to the clinical presentation of the symptom and the patient, but they don't take any care about what are the expectations of the patients for the treatment and basically what are the expectations of the partner about the treatment. So this makes a lot of differences because all this stuff are present in the guidelines. But if we take a look at the guidelines, all the guidelines just take different decisions related to different procedures just regarding the prostate feature or patient features, but they don't take care at all about what are the patient will and desire about the treatment. So basically, what have moved the technique in the evolution are mainly these three different categories. So if the patient is a high-risk patient, if the patient can go under anesthesia and so make surgical procedures, and basically also if the patient may stop an anticoagulation therapy or antiplatelet therapy. And also if the patient is young, or maybe if the patient just desire to spare the ejaculation. So these are the drivers that are mainly guided the evolution of the surgical treatment for BPO. And basically, this is the reason why the surgery has evolved from the open surgery, which is a very old therapy that we apply since several years. The open surgery has moved to the endourology and then to the minimal invasive surgery and then to the micro-invasive surgery, which is something that we will talk later on during the webinar. So basically, the new device and techniques are aimed to reducing the intrinsic invasiveness of BPO treatment and also are aimed to try to spare the ejaculation. So basically, if we take a look at the guidelines, we have just one device which already is present in the guideline, which is the UroLift. But there's no any one word spent about what to do if the patient wants to spare the ejaculation. And what is important is consider that a major limitation of the available evidence about new micro-invasive techniques is that the obstructive effect is evaluated just using criteria like UMAX established for standard procedures like URP. But is that the right way to proceed to judge and to give to have any clear idea about this ejaculation sparing technique? So is the right things to do just compare this technique to the TURP? I don't think so. And this is what we are trying to assess today with the discussion. So at the end of the game, what are my questions, and what I hope that we will be able to give some answer is that should we offer to the patient today surgical approaches with the ejaculation sparing technique? And if yes, how many patients aim to preserve the ejaculation? And so what are the patient expectations? And what about the partner? So what are the partner expectations? So for the moment, thank you for your attention. And so I would like to introduce the next presentation. So we can move to the next presentation, which is, I already said, the Silvia Secco, that we talk about the Eurolift. So please.
Thank you very much. So first of all, thanks for the invitation. It's a pleasure to be part of this webinar. It is very interesting. It's something that we know is very important for us, for the patients. So let's talk about it. And as you have actually said, Eurolift is nowadays the only minimally invasive treatment that allows to maintain the ejaculation. But maybe you have listened the name Eurolift, but many of us cannot know what Eurolift is. And I'm trying to explain. So we should consider Eurolift as a small permanent implant that is placed into the prostate. And its purpose is to lift and hold the enlarged tissue of the prostate. So we move out of the urethra, the prostatic tissue that creates the obstruction. There's no cutting, no heating, and no tissue removal. So it can be really considered a real minimally invasive technique. And the Eurolift system has two main components. The first one is the device. There's a picture of it. And as you can see, there's a button that is a safety lock button. And the other one, number 2 and 3, help us to release the needle and also the device. This is the permanent implant, and so the most important part of the Eurolift system. It's a suture, a PET suture with 2 pieces at the end. One is on the urethral side and one is on the capsular part. Both of them, the urethral and the capsular pieces, are stainless steel, so there's no problem for the patient. And the length of the suture is per prostatic lobe. But how does the Eurolift works? Through a compression. The compression of prostatic tissue creates atrophy and ischemia. And atrophy and ischemia are stable for more than 5 years, as demonstrated by several papers that have been published. I'm going to show you how it works in a schematic way, and then we've got 2 short videos that can help us to really understand the technique. So first of all, we start with the device into the bladder. Then we position the device far away from the bladder neck. 1.5 centimeters is what is always suggested. This is a main role for how the implanters, as we call us. Then we need to compress the prostatic lobe, and the compression is very important to obtain a good result. Then we unlock the safety button and we press the other button to deploy the needle. After that, another button allows us to retract the needle so we can reduce the angle slightly going through the prostatic lobe. And then when the suture is into the keyhole, as shown on the right picture and point out by the arrow, we can release the needle and the stitch. So we can press the urethral release, pivot the device into the midline, and then advance into the bladder, rotating the device and then removing the device from the shelf. The shelf stay into the bladder, and then we need to recharge with another device, the Eurolift system. This is a procedure, a rendering one, that can show us what I have told you. So we compress the prostatic lobe, we release the suture, the two tabs are released, the capsular one and the urethral one, and then we perform the same procedure on the other lobe as many times as is needed to obtain a good channel. And the channel that we will obtain at the end of the procedure, as is shown here, is different from the one that we obtain after a classic TURP, that, as we have listened from Professor Bove, is nowadays our main point for referring to a classical BPH procedure. And this is what happens in reality. So first of all, we perform a cystoscopy to check that everything is fine and that nothing has changed from when we have first evaluated the patient. And then we're going lobe by lobe to release the implant. So far from the bladder neck, 1 centimeter lobe, and then looking that the suture is in the correct place. So like here, we're seeing on the keyhole, we can release here, okay? So we can now release the first urolift. And then we perform on the other side the same maneuver. After 2 urolift, the position is advisable to repeat a cystoscopy to see if there are still any obstruction and eventually to decide where to put the other devices. Let me say something about the position. The patient is in a supine position, a gynecological one. You can, of course, perform in general anesthesia, but nowadays we are performing in local anesthesia so that the patient can go home after a few minutes, few hours of the procedure. And this is a big advantage also speaking into this particular era where the COVID has conditioned our life and our occupation of the theater. We gave to the patient an antibiotics before the procedure, and we suggest the patient to maintain the therapy for other 4 or 5 days. As you can see indicate in this particular patient, no hematuria is happening. Hematuria is very, very rare. And also the catheter position is very uncommon because urinary retention occurs only in less than 5 patients, 5% of patients that we treat. And at the end, we perform another cystoscopy to verify that we have obtained a good channel. So after this, we have to keep in mind, good, urolift is a very minimally invasive technique, a very minimally invasive option. So when we can think about this procedure for a patient, and to illustrate you which are the patient selection. So all BPH patients that are keen to preserve ejaculation can be treated with urolift. And also, if these patients want an alternative to medical therapy or are concerned about surgery, they don't want to perform the procedure on a spinal or on a general anesthesia, or are looking for something very that is not invasive at all, or are concerned about complications. And also for patients who want a really rapid recovery, because we will see that patient after the urolift position can go home and do the normal activities the day after the surgery. But we cannot use, or better is contraindicated to use the urolift in patients whose prostate is larger than 80 cc, or patients that have a urinary tract infection or urethral stenosis, or of course hematuria that is ongoing, because it's not necessary to say that we have to perform other things before this particular treatment. And to select the patient, of course, we have to perform the uroflow, the PSA, anamnesis, and so on, but we suggest also to perform a flexible cystoscopy and an ultrasound of the prostate. Can be an ultrasound transabdominal or transrectal, but we have to know how is the prostate in terms of dimension, in terms of shapes, and to know if there are any kind of stenosis or something that can render the procedure so difficult. So we have to collect as much as information as we can to be sure that the procedure will have no complication and no contraindication. The fact that the patient uses anti-aggregation or anticoagulation medication is not a problem. We can perform it as well. Lots of literature have been published regarding the Urolift, because Urolift is a procedure that has more than 10 years of experience on its back. And so we should point out that the 5-year data demonstrates that the outcomes are rapid, but also durable and reproducible. So quality of life and flow max and the advantages that we have achieved in these parameters are stable and durable. And moreover, the Urolift offers superior symptom reliefs and less side effects profile compared to drugs. So in terms of EPSS improvement at 12 months, we should see that there's an improvement of the EPSS of more than 10, 11 points, and that in all the patient treatment, there's no erectile dysfunction, but moreover, no ejaculatory dysfunction. But also the Urolift offers better recovery compared to surgery. In these studies have been compared TURP and the laser treatment. So the patient after the Urolift can come to his habitual and problems after 5 days, and only in 20% of patients a catheter is placed. And also here, no ejaculatory and no erectile dysfunction problems. It's interesting to underline how the Urolift patients are satisfied sooner and with a greater extent compared to TURP patient, even if his EPSS is not as much higher as the TURP, and also not the flow max. Maybe because if we have well selected the patient and the patient after the procedure can still ejaculate, is still happy, and so is really satisfied. All these data have allowed the Urolift system to be part not only of the EAU guidelines, but also the AUA guidelines. And in both of them, there's a strong indication who to maintain ejaculation, of course, whose prostate are not larger than 80 or 70 milliliters. In the EAU guidelines, it said that no median lobe have to be present, but I want to tell you that you can perform the Urolift even if there's a median lobe, but of course you have to be a little bit skilled, and the median lobe have to not completely ostrent, because otherwise will be difficult to treat. So to summarize, for who? Urolift is for patients who are keen to maintain ejaculations and wants a rapid and stable response and relief. It has the lowest catheter rate compared to the other BPH procedure and has a proven durability throughout the 5 years. We should consider the Urolift as a bridge between the less invasive technique, such as watchful waiting or medication, laser or TURP. So keep an eye on it, and thank you very much for the attention.
So we can move on with the next presentation, which regards the ITIN device, and the next speaker is Dr. Riccardo Bertolo.
So the temporal implantable Nitinol device is another of the available treatment options to be micro-invasive in treating the benign prostatic obstruction. So this kind of device is called temporary because instead with respect to the Urolift we watched about by Dottoressa Secco, is something that is temporarily implanted in the prostatic urethra. Is a 15 minutes office-based procedure. It's virtually painless with no tissue trauma in the prostatic urethra. There are no blood losses recorded. It could be performed in the light sedation or in a general anesthesia way. It's very easy to master, and the learning curve is extremely short. the patients are usually discharged on the same day, and there is no need for postoperative catheterization according to the factory producing the temporary implantable digital device. This device has known a first generation and a second generation with some features different comparing the two kind of devices. The first one is called the TIND, so the temporary implantable digital device with 4 Nitinol struts. They are meeting at the anchoring leaflet, and there is a soft plastic material that is protecting the tissue trauma of the bladder, because this kind of tip was touching a voided bladder. The tail of the device had the nylon wire, that is the Ariana's wire for the retrieval of the device. The total length is 50 millimeter, and the outer diameter is 33 millimeter. The struts were designed to perform 4 incisions. Then the second generation of the device is pretty similar, but only 3 struts are used. There are intertwined Nitinol struts that are configuring a tulip shape, and they are performing just 3 incisions. There is no tip, so there is no plastic cover to avoid the tissue trauma, because there's no risk of trauma of the bladder. The procedure is, as I said, is pretty easy to be mastered by using a cystoscope inserted transurethral. We are getting into the bladder, and then the device is positioned after orientation and anchored at the level of the urethral, prostatic urethra. Within 5 days, around 5 days, 7 days, the struts are pressing against the bladder neck and the prostatic urethra, leading to targeted ischemia that is configuring the incisions. So you can see the radial force exerted towards the prostatic urethra with a scheme showing the before and the after with respect to the procedure. Obviously, you can figuring that there is no damage to the anatomy of the ejaculation. The removal is pretty simple, can be performed by using a cystoscope with retrieving the tulip temporary implantable Nitinol device into the sheet of the cystoscope, but could be performed even by simply using a catheter that is cut at the level of the tip. The wider is the catheter, the easier is to retrieve the device, and I usually prefer using the catheter, which is much easier and faster. The literature data about the temporary implantable Nitinol device started with the first generation that is now out of the market. The first ever study was performed on 32 patients. I am pretty familiar to this research group. The prostate volume was below 60 milliliter, and you can see the patients were obstructed with an average Qmax around 7 milliliter second with a high IPSS. There were no intraoperative complications, and just a couple of postoperative complications, including urinary retention, transient incontinence due to the device displacement, that is something that has to be considered, and prostatic abscess in one case, and urinary tract infection in another case. The urological point of view of this cohort was pretty good, because the patient improved in all the IPSS, the quality of life, and the maximum urinary flow rate. Around, you can see 100% in the Qmax and 50% reduction in the patient-reported outcomes. The cohort was followed up till 3 years. We confirmed that the Qmax and the IPSS and quality of life were almost stable over time. Ejaculation was preserved in the 100% of the patient. There was a 5% of treatment failure rate reported. Then the literature is moving up with the data about the iTeam, which is the second generation. This is a very interesting study where the authors, investigated the pain level related to the device, which is pretty high in my feeling, in our experience. So the VAS score, the visual analog scale, is not 0. And many patients are reporting a discomfort that is perioperative and even postoperative. In total, this author reported 12 out of 81 patients who reported a failure in the treatment, and half of the patients who failed had a median lobe. So median lobe is not a good indication to this kind of device. This is a study reporting the 3 years results of the second generation, and you see that the results are confirmed. So there is a 100% improvement of Qmax, that is going from 7.8 to 15 milliliters per second, and a reduction around 50% of the patient-reported outcomes. And again, the authors underline that there is a 100% ejaculation sparing intent reached. So the summary of the literature-based current indication of this kind of technique is there are no age limits. The IPSS symptom score has to be over 10. The maximum urinary flow rate below 12 milliliters seconds. No that big prostate volume, so it is advised to stay below 75 milliliters with no median lobe. The cohort of patients to whom dedicate this kind of technique is very selected. So patients who generally refuse Turner's treatments because they are afraid of losing the ejaculation. So they have a strong need of sparing the ejaculation. The conclusions is that obviously temporary implantable Nitinol device is another option, witnessing the evolution of the treatment, of the micro-invasive treatment for benign prostatic obstruction. This is another technology pushing the limits of the treatment towards the outpatient setting and the ejaculation sparing. The data are till the 3-year follow-up, so they are encourageable, but there is no data enough to be guideline recommended. I always tell my patient this kind of analogy. So with the drawbacks of the electric car are very similar to the drawbacks of a micro-invasive techniques. So you see that if you buy an electric car nowadays, the electric car has nice, fascinating, promising pros, but there are a bunch of drawbacks that you can read. So going for a micro-invasive technique today is always agree to a compromise, to accept the possibility of not being completely, fully deobstructed, but maybe have the warranted sparing of the ejaculation. Thank you very much.
So thanks a lot, Riccardo, for your brilliant presentation. Thanks a lot.
Thank you.
And we move to the Dr. Caffarelli and Dr. Tallè for their presentation about the Resume device.
Thank you very much for your invitation. We are Dr. Matteo Tallè and Dr. Angelo Caffarelli. We work in robotics and minimal invasive urology at Villa Egea Private Hospital in Ancona. I am a consultant. He is the chief of the department. We're going to talk about the Resume. We are, as a center, we have a long experience on HOLAP, and we started this kind of procedure since a couple of months. And so what is the Resume about? First of all, in Italy we call it Resume, but I've heard that the right way to go is Resume, and Resume, it sounds at least to me like resume, so getting back from something, or restore. And what it's about using water vapor. I was told that one of the ancestor of this kind of intervention is TUNA. So how do we deliver the water vapor inside the prostate tissue? We deliver by injecting with needles. So we enter the urethra, and then we inject with needles on the prostatic lobe, or the prostatic lobe that are obstructing. And what is happening here? Basically, we induce cell necrosis. How do we do that? With the thermal energy, because when water vapor, that is steam, shift to liquid, it releases a lot of thermal energy that has been stored. So that's kind of the procedure that use resume. The surgical technique is, I would say, it's simple. It's at least to us that we are used to HoLEP. HoLEP is quite a complex procedure with a long learning curve. This is simple, and the learning curve is I would say it's short, and it takes about 5 to 10 minutes if you are an amateur. And what you have to do is basically you get inside the prostate, the urethra, with that delivery device you can see on the imaging, and then you measure the distance between bladder neck and verumontanum. How do we measure the distance? By using our unit of measure is the fields of view. Fields of view is 0.5 centimeters, so 5 millimeter. That okay, I got a slide that demonstrated. So basically, you go from the tip of the delivery device to this point of the branches. This is one field of view. It is very, very important because let's say that each field of view corresponds to one injection. So the number of field of view, it's related to the number of injections you do. Each injection lasts 9 seconds. If you're able during your injection to reach 7 seconds, then that is fine. But if you're not reaching that cutoff, you have to do it again. So after you've measured the prostatic urethra, then you turn 90-degree left and 90-degree right, and you go with your injection. How many injections do you have to make? I've already told, it depends on the fields of view, but we have a formula, let's say like this, that McVary told us with his researches, that we should use one treatment per 9 millimeter of the prostate volume. So it means that we have this simple, I would say, equation. So if we have like 60 of prostate volume, you should do 6 injection. If you have 55 and so on. So that's quite simple to remember, and a good way to remember it. Be aware of overtreatment. What do we mean? Because especially if you come from a HoLEP experience, you're used to see the effect of the laser on the tissue. Here, after you remove the needle, you don't see nothing on the tissue suddenly. So I would say that a surgeon, above all an amateur, is going to do another treatment, but it's not necessary. It's just something that will cause dysuria and hematuria to the patient. So that's something that we want to avoid. We can treat a third lobe, medial lobe. You have to go for another injection. It depends on how much a medial lobe it's large. So a field of view, we've already talked about this. Let's move on. Ejaculations pairing. So one other advice that we add is to stay 1 centimeter above the ejaculation triangle. What is ejaculation triangle? Everybody knows it's a triangle with the apex. One apex is the right ejaculatory duct, and the other is the left one. And the other is the verumontanum. So the advice is to identify the duct and stay above the duct. How do we assess the ejaculation? By using the validated questionnaire, the men's sexual health questionnaire. We got especially the ejaculatory disorder short form with the 4 items that are about the ejaculation. So the indication, as we heard before by the presentation of the Dottoressa Secco, a resume is something that is in between a classical surgical procedure, let's say like this, like HoLEP or TURP, and medication. So something in between is patients who wants to preserve ejaculation but doesn't want to have the side effect of the medication, or wants to get rid of the medication. And so we can treat prostate that is from 30 to 80, and that's how we should consider this kind of techniques. This is a slide that I've taken from Mayo Clinic of New York. So you see, it's quite clear here that means, so the minimal invasive surgical technique is something that is in between a definitive technique like HOLEP, where you have the augmentation of Qmax plus 14 milliliter per second. You see the resume, you have plus 3.5, and the molecular therapy plus 2.4. So it's something that is really in between. But if you see the ejaculation, it is spare in the 98% of the cases. If you see a HOLEP, you lost the ejaculation in 80% of the cases. So you can maximize the good effect of medication with less invasiveness. And so you see, as the effectiveness grows, so the invasiveness does. Surgical outcomes. This is really, really important, because one of the things that really can disturb your outcome, let's say like this, can make you fail as a urologist, is the patient expectation. Because the patient, what you have to tell to the patients that you're not going to get better soon. You have to wait 3 to 4 weeks before you can improve your symptoms. So you can have 2 to 3 weeks of urgency, frequency, and dysuria. And then as a follow-up, we used to do a voiding trial between the 3rd and 7 days. Median on the 5. We go for 5 days actually, and then a visit of 1 and 3 months. You can win from alpha blocker, so we discharge all the patients with alpha blocker and glucocorticoid. So we saw that 20% of the patient gets better soon, immediately, 25% of the patient in 2 or 3 weeks, and 30 to 40% of the patient in 1 or 2 months. So the advantages, what are the advantages for the surgeon? Because it's easy to perform, especially if you come from complexity like HOLEP and other techniques. It's easy to perform, it's fast, and it's the quickness of the maneuver. So 5 minutes, that's the mean, more or less. For the patients, one of the advantages that you go for just a mild sedation. The hospital, no need for hospitalization. You can also be treated in an office setting, and you can save your ejaculation. There's no need to suspend if you're not able to the anticoagulant drugs. The guidelines, European guidelines, are quite enthusiastic about the technique, but what we have to say, what the guidelines tell us is that there are no data, above all mid and long-term data, to confirm the result. But as you see, they define it promising. So especially we're lacking RCT control against the reference technique. So that's will be the way to go for the years to come. The American one is the same. The results, the data are promising, but you see the recommendation is moderate right now, and the level of evidence is a C level of evidence. Let's talk about scientific literature. This is so far, to the best of our knowledge, this is the longest. This is the study, the RCT with the longest follow-up, which is about 4 years. 4 years of follow-up. This is was done by McVeary from Chicago, and you see this is a RCT versus a group treated versus a control group. There are improvement on all the parameters of urodynamic parameters, and these improvements stay stable for 4 years. The reintervention is about 4% in 4 years, which is quite low. It's lower than other MIST. And they have some minor complication. The same you can have on a cystoscopy. Preservation, sexual function is good. It's good. You see, there's no lowering in ejaculation, and while there is improvement on a PSS and Qmax and the other aerodynamics parameters. So this is a RCT from the same group of McVeary. This is an interesting study that confirms. This is a British study that confirms the results the American had But one thing that is quite interesting that I want to point out is that during this era of pandemic era, it sounds really appealing to the patient, the fact that that they're not going to be hospitalized and they'll stay at the hospital for 2 or 3 hours. So this is really appealing, and we should consider this, especially during this coronavirus era. Another study, this was published on Journal of Urology. What I want to point out of the study is that we, with medical therapy compared to Resume, we had 5 times greater progression of BPO. This is something that is, to me, at least to me, should be considered. Prostate greater than 80 milliliter. Can we treat it? The authors of this study, this is came from 2021. They are really enthusiastic about this, but if you see the result, nearly 2/3 of the patients still need alpha blockade. So it's not. I won't be that enthusiastic, but you know, things we will see in future to come what is going on. Last thing. Cost effectiveness. Resume is a good technique. As I told, is something in between a definitive surgical treatment and medical therapy. It is not that expensive compared to other, for example, to UroLift, and is more expensive than combined therapy, but it is really more accurate. It has a greater efficacy. So what the take-home message is this is a good technique to spare the ejaculation, but it should be considered as an alternative to medical therapy rather than to a whole up on a definitive treatment. That's it. Thank you very much.
Next, and less presentation about different techniques, which is the PAE, so the prostatic artery embolization, and the presenter is my good friends Antonio Galfano.
So I will speak about prostatic artery embolization. It's a really particular topic, and our hospital was one of the first in Italy to start with this particular procedure. I just a disclosure, I have no conflicts of interest. I have only to thank Silvia Secco that spoke before because she provided useful material and data for this presentation. I won't tease you, I'm the last one, or almost the last one, to speak about this topic. I won't tease you about the standard surgical treatment for BPH. I want to show you the main limitation of this treatment, and you already talked about it. They need for anesthesia, they are invasive treatments, they have bleeding risks, and they need hospitalization, and they have retrograde ejaculation as long-term sequelae. In my hospital, there were local issues that pushed us to start with this kind of treatment, because we started from a period of very long waiting lists for benign pathology, because we had long lists for oncological issues. My hospital is a tertiary referral center, so we had lots of high-risk anesthesiological risk, I mean, patients. And at the time when we began this adventure, we had no laser for BPH. So we were somewhat in troubles to treat adequately BPH. And interventional radiologists that were great friends, we work into 2 rooms that are confining, that are bordering. So we were always talking about common problems, and we started with this collaboration. Francisco Carnevale from Brazil published the first 2 cases of PAE in 2010, and since then he spread his technique and his approach all over the world, also in Italy, where he came to our hospital to start with this procedure. In the years, the procedure changed somewhat and improved and was refined and was standardized, most of all. All patients undergo a Clisma fleet the day before. They put a Foley catheter for Team French during the procedure, and if they don't have a catheter before, they remove the catheter. They have an antibiotic prophylaxis. The procedure is done under local anesthesia. with a unilateral percutaneous femoral approach. In the last year, the radiologist started to do a radial access that is really useful to do the procedure as a daytime procedure. And they define the procedure as a technical, not clinical, but technical success when they can embolize both sides of the prostatic arteries. The technique is acronymed as a perfected technique, and the real trick is to go distally. The term prostatic artery embolization is not so precise because the radiologist that does not embolize the prostatic artery, but embolizes the intraprostatic branch. I don't know if you see my arrow. But they go inside the prostate and they embolize the branches of the prostatic artery that go towards the adenoma. So it is a really, really selective procedure. And that is the reason because they do not have problems with the rectal arteries and vesical branch. So the only way to avoid the embolization of other organs is to go very, very, very distally. The parts that are used to do the embolization is the embosphere, that is a 300 to 500 micron. And the other very, very important trick is to inject very slowly the parts, because if you inject quite quickly, the risk is that the parts come back to the main artery and go to other arteries. So the tricks to avoid complications are technical tricks. So the main limitations that we saw with the main surgical approaches are completely disappeared with this kind of treatment, because you don't need for anesthesia, it is not an invasive treatment, you don't have bleeding risk, they do also under Coumadin, you don't need hospitalization, and you don't have retrograde ejaculation. We started our collaboration beginning from our worst patients. So the radiologists wanted to start. We didn't want to lose pathology. We were really fearing to give our patients to the radiologist. It is somewhat a renunciation of what we usually do. So we started giving them the patient that we would never operate. So the 90-year-old patients with 2 strokes and that cannot go outside home because they have a catheter. Okay, the classical patient that your anesthesiologist will tell you, okay, you are crazy. The patient will die in a few years when it will be his turn with this catheter. Okay, we started from this with these patients and published our experience, and the results were that in these cases that they are the really bad patients that will die with the catheter and that will have a bad impact on their quality of life for the catheter. We had more or less 70% of patients that could remove the catheter and that stayed without the catheter. So it was considered a good success. After this experience, we expanded the indications, always giving to the radiologist other patients, patients with bleeding risks that did not accept to have retrograde ejaculation, or really young men under 50 that wanted to improve their urinary situation, but that wanted to continue to ejaculate. By now we are at more than 400 patients treated, and in this big series we have also patients that any urologist would never give to a radiologist, because we probably there are a 20 to 30% of patients that we would like to operate. Okay, but still there are 40% of these patients that had a catheter during that were referred to us because they had a catheter, and that wanted to be operated, but we did not have room in our operatory room to operate them. And so we confirmed that mostly there were patients with lots of comorbidities, so you can see from this slide. What happened was that the complications were quite low. We did not have any Clavian 3A or 3B complication. The most frequent complication was urethral burning. Rectal discomfort was very rare. We did not have any single case of rectal ischemia or bladder ischemia or problems of erections after this kind of procedures. You can see that most of our patients had problems of erections just before the procedure. So it was not a big issue in this series. We could remove the catheter in the patients that had the catheter in more than 70% of patients. So it was a quite good situation. You can see that the median reduction of volume of the prostate was about 30%. And so it was quite a selective reduction of volume, because it was the needed volume, because the embolized adenoma was the part that anatomically showed its obstruction. So it was a desired decrease of volume. By now we are studying the different indications, and what we can see is that the best results are in very large prostates. We are studying about the treatment of median lobes that can be embolized selectively, and it was a good success in the retrospective analysis of data. We are studying what happens to patients that are undergoing PAE with a PIRATS 3 lesion, and what happens after biopsy. Obviously, what happens is that mostly they have a downgrade to PIRATS 2, and they have a reduction of the dimension of the lesion of the PIRATS 3. Okay, we are going on with a multicentric Italian experience. We have five centers that are giving us data, and we are collecting the results. And probably, if the abstract will be accepted, we will show it at the EAU Congress. But what is happening in the other states and in Europe is that in the last month, the first long-term single-center randomized clinical trial was published comparing PAE versus TURP. The results were obviously in favor of PAE for what is regarding complications, because PAE has really, really low complications compared to TURP. But really, about the outcomes, there is no way. TURP is more effective than PAE for both for subjective outcomes and for objective outcomes, prostate volume, PSA, flow, uroflowmetry data, and so.
Antonio, can I ask you to go to the conclusion, because we are a little...
It's the last one, okay. The EAU guideline confirmed that PAE is less effective than TURP, so we have to just try to find the good indication. And the good indication is that PAE is not an alternative to TURP. It is a good alternative for selected patients. You have the drawback of radiological exposure, but probably the possible scenario is not the alternative to TURP that remains the standard, but it's in the middle way between the drugs and the surgical options.
So thanks a lot for your nice and complete presentation. Go back to the presentation that we lost about the aqua beam. Dr. D'Agostino is ready.
Okay. I will speak about aquabeam, about prostatic ablation through the water jet. So the aquabeam is a robotic system, is a robotic approach for treatment of BPH, and the aquabeam is the combination of three important aspects. The first, the imaging, the check in real time of imaging in the treatment, the robotic ablation of adenoma, of prostatic adenoma, and the energy, the water jet, the ablation of prostatic adenoma through a water jet, a high power water jet. It's very important to consider the water jet because the power of water, the power of water jet is important to ablate the prostatic adenoma, but it's very important to preserve the structure really important in the prostate, such, for example, the vascular tissue and muscle tissue. This aspect is very important to preserve the anterograde ejaculation of patient, because the preservation of muscle tissue, of bladder neck, and of ejaculative ducts is very important to preserve ejaculation in these patients. The preservation of vascular tissue is very important in point of view of bleeding after this procedure, because the real problem of aquabeam is the hemostasis, because the water jet not perform hemostasis after the treatment. The procedure is ultrasound guided, real time. We have axial view, ultrasound view of prostate, and we can identify the treatment area in adenoma, in central adenoma of prostate. We can identify the median lobe, the lateral lobe of prostate in axial vision. In sagittal vision, we can perform we can identify the principal point of start of treatment near the median lobe, the bladder neck, the middle prostate, and the apex of prostate. The procedure is step by step. In a first step, we can set the handpiece of the aquabeam, and we can set the truss, the ultrasound for the plan the treatment of water jet. In a second step, we planned the angle of resection and the area of resection, and the last step is the treatment, is the ablation with the water jet. In this slide, you can see the principal step of planification of resection of BPH in the axial vision and sagittal vision. This is the treatment. The time of treatment is very, very low. We can treat the prostate with a large volume in 5-6 minutes. In this video, you can see the treatment, the ablation of prostatic adenoma with aquabeam, with water jet. You can see the time of treatment is very, very low. So, about the hemostasis, in literature, only 2 techniques are considered for hemostasis after aquabeam, in particular bipolar energy and laser energy. In literature, it's considered principally the bipolar energy for hemostasis after aquabeam treatment. Holmium laser is very not considered for hemostasis after aquabeam. This is the endoscopic vision after treatment. You can see the cavity of adenoma after treatment. Our experience, we have treated the 53 patients in our department with a prostate volume of a mean of 58 cc, and you can see in the table the principal results of our analysis. The rate of a anterograde ejaculation preservation is about 80%. Thank you for your attention.
Okay, thanks a lot to Dr. D'Agostino for this presentation, and I think we can move towards the next presentation, which is my presentation. So now it's the moment to start with the presentation of this new device, which is the SoracteLite Transperineal Laser Ablation for the surgical management of non-surgical management of BPO. And with this presentation, we will move from a mini to a real micro-invasive treatment, which also is we'll not use the urethra to go for the treating of BPH, but we will move from the outside to the inside using the perineum. So what is the SoracteLite? So LS EchoLaser thermal ablation for treating benign and malignant urological pathologies. With this device, we can treat, in regards of urological procedures, we can treat BPH. We can also treat with the same machine. We can make some focal procedures for prostatic cancer, and we can also treat with the same machine kidney cancer, so small renal masses. We will use the SoracteLite to determine a volumetric reduction of the enlarged prostate, so we will have a cytoreduction effect induced by the laser ablation, which is a coagulative necrosis. And we will produce a complete ablation also of malignant tumors. We have started the experience since about 1 year, I guess, and now we have some results that we will show you during the next presentation. So where does the SoracteLite names come from? So the name of the treatment contains in a single word the connection with the urological application. So Soracte is the name of an Italian mountain very close to Rome, also named in the incipit of an Horace poem, where there was a monastery in which the monk Nonnoso, canonized, is considered the protector of people with kidney disease. And also the light, so the last part of the SoracteLite name, on one end refers to the lightweight and micro-invasiveness of the treatment, and on the other ends refer to the therapeutic source, so light and therefore laser. So the treatment is obtained by the use of a percutaneous insertion of optical fibers using, as I already said, the transperineal access. And we will take in place 1 or 2 fibers per lobe, depending on the volume of the prostatic gland. And once we have taken place the fibers, we will deliver a laser energy for several minutes, depending on always the prostatic glands and how many treatment we will decide to perform. So who is the best candidate for the procedures? We are still investigating. This is a very new technique, so it is still under investigation. What we already know is that we can treat patients with refuse surgery or patient we cannot underwent to surgery for a lot of comorbidities. So we can use this treatment for all the patients who desire to spare the ejaculation. And one of the critical points is that we can treat only prostate which have more than 30 milliliters in volume. And this is for a technical point of view that I'll show you later on. And we are still investigating, in my experience, if we can and how we can treat patients with median lobe or patient with a very large or hypertrophic posterior vesical lip. And also we are investigating which is the best prostatic volume to obtain the best results with the technique. So this slide show you what are the treatment phases of the SoracteLite. So at the beginning, we take in place a 3-way Foley catheter just to control more than the urethral temperature, just to control and assess where is the urethra under ultrasound examination. And then we perform the transurethral ultrasound in order to define what is the prostatic volume and what is the prostatic morphology of the gland. Then we will move to the local anesthesia. We can use some cream just to avoid any kind of pain for the patient. And then we will perform a perineal skin anesthesia using lidocaine 2%, 5 to 10 milliliters. And then we will move to the periprostatic plexus using some more lidocaine. And then if required, we can have also some conscious sedation. Then is the moment to place the fibers in place, and we will use 1 or 2 fibers per side, depending on the prostate volume and morphology. And then we will start with the ablation. Basically, the ablation is 1800 joules per fiber with 3 watt. And if necessary, always we will make a pullback technique, just 1 or 2 centimeters towards the apex, in order to treat the most apical part of the gland. The treatment planning for BPH is a very important phase. And basically, when we perform the ultrasound examination, we have to keep in mind where to position the probe, what are the needle insertion path, and what are number and distance of the needles, where to take in place the needle tip, and also the area size, taking in account for safety distance between the capsula, from the bladder neck and from the urethra, basically. And then if we need to pull back at the end of the first time procedure, just to treat a more amount of the gland. And this is basically what we do. So you can see in this picture some images of the prostate, and this is what we have to know. So with the fiber that we use, we will have a diameter in height of about 16 millimeters, and a length of the laser abrasion, which is going to be about 22.5 millimeters. And this is the area of treatment for each fiber that we use. And these are what we have to keep with very attention. So what are the safety distance from fibers to critical structures, which are urethra, as you see here, where we have to keep at least about 1 centimeter. And also we have to keep 1 centimeter from the capsula. And also other very important distance that we have to take in account is the distance from the bladder neck, which has to be about 15 millimeters. And this is what we use. Okay, so it's very easy to prepare technique. And this is the device that we have. This is the brand new machine that we use, which has an integrated ultrasound machine. And this is the software for planning the fiber positioning. And we can also use the EchoLaser Smart Interface which represent the unique way to integrate different technologies, including a generic ultrasound linear probe scanner for thermal ablation procedures. And these very nice systems allows the visualization of fiber insertion trajectory through dedicated needle guides mounted on the ultrasound probe, as you can see in this image. And a dedicated simulation for each fiber allows the user to plan the treatment and to easily reach the treatment tissue, even in hard-to-reach anatomical sites. So this is valid, especially in very large prostate. This is the multi-applicator guiding system that we can use, especially for people who are not very well trained on transperineal prostatic biopsy. So this is an easy way to proceed to insection fibers using just this very small and easy to taking place device. And this is what we can see during the treatment. So once we start with the procedures, we can see some bubbles generating from the high temperature that we reach inside the prostate. And this is also an image of the active treatment that we have on the screen. And this is the color of the urine at the end of the procedures, which you can see is very clear with no any kind of hematuria. So we can check the performance during the procedures, and we can check the result after a couple of hours from the procedures, especially if we can use ultrasound contrast enhancement technique. And this is the pharmacological treatment that we give to the patient after the procedures. Mainly we use some corticosteroids and gastric protector, and then we use the antibiotic for 7 days, and then some suppository of anti-inflammatory like Oilis for 7 days. As regard the treatment performance, the catheterization is up to 7 days. It depends on patient characteristic on the prostatic gland. So I cannot give you just an exactly number of days to keep the catheter in place, because for example, patients who come to us with an indwelling catheter may need at least 14 days before they are able to remove the catheter. So the effect of the treatment also we have to take in account that it is not immediate, but it takes few days before starting the site reduction process. So basically it comes after 4 up to 8 weeks after treatment. So this is the time that the body needs to gradually reabsorb the tissue treated with SoracteLite and to decrease the pressure of the adenoma on the urethra, and so to reduce the BPH related symptoms. So this is basically what we check in the follow-up. We check the IPSS score, quality of life. We have seen what is the pain of the patient after the procedure using a BAS scale. Also, we check the IIEF, so the International Erectile Dysfunction Questionnaire. We use obviously the Qmax with the peak urinary flow just to assess the de-obstruction of the procedures. Then we check the postvoidal residues, minor and major complication, and possible side effect. So we have just few weeks ago presented to our ethical committee our study that we are running, and it is a comparison between the SoracteLite treatment for benign prostatic hyperplasia towards the standard, which is the TURP. Obviously, the main objective of the study is not to compare the de-obstruction effect of the technique, but to compare to the TURP in terms of ejaculatory dysfunction and sexual dysfunction, which is, I think, one of the main goals that we have to take in account with these procedures. So obviously, these techniques has a lot of advantages because mainly it is possible to preserve healthy tissue and the prostatic organ function. There is a highly predictable and repeatable coagulation volume that we can check during and after the procedure. We use fine and very atraumatic needles with the transperineal approach. So you have to believe me. So the patient doesn't feel any pain. The only discomfort is the catheter, but it's a very tender Foley catheter. So basically, this doesn't give a lot of pain or discomfort to the patient. There's basically an absence of general anesthesia. So it's a kind of procedures that we can run in outpatient basis. And it's a very short procedures. It takes just a few minutes. Normally, once we have performed the anesthesia, it's going to take about 10 to 15 minutes. It depends on the expertise and the experience that the operator has in placing needle in the prostate. So if you have a very good experience with the perineal prostatic biopsies, this procedure is going to be very easy. There's a very rapid recovery time, absent of mild post-treatment pain, as I already said. There's no significant incident of complication of the ejaculatory function, and no reported at all complications such as urinary incontinence of erectile dysfunction related to the procedures. So you will see all this data, I think, in the next presentation, and I'll thank you for the attention. And also we can move to the next presentation. So I think it's Professor Nitinol is going to present us some result about the techniques. It was one of the first user of the machine, so I'm very happy to present him and to stay here and see what he has to give us in terms of results. So thanks a lot.
Hello. Yes.
Hello.
Thank you for the kind invitation, Pierluigi. And I'm going to present just the clinical evidence we have so far with the SoracteLite. Basically, we start with the consideration that in the treatment algorithm of BPH treatment, there is a steep gap between pharmacological and surgical therapy in terms of invasiveness and also postoperative consequences. And we know also the choice of the technique depends on several parameters such as prostate size, comorbidities, ability to undergo anesthesia, patient preference, willingness to accept also the side effect of surgery, also the availability of such armamentarium, and also the experience of the surgeon. So for this reason, there was a continuous search for new so-called macro-invasive alternatives. We know that there is a strict correlation between efficacy and the invasiveness of the procedure, as has been shown also by others, and between, watchful waiting medical therapy and the surgical approach. And so macro-invasive, we put like a bridge between these two kind of procedures. What is micro-invasive treatment? Should be a treatment that doesn't need a general or epidural anesthesia, should be done on a patient way. There should be sexual side effects, and there should be very low risk of complication. If you are old, who is old as me, has been started this kind of procedure in the late 80s with thermotherapy as TURP of tuna that are not used anymore. And now there are many new ways like prostatic stent, prostatic laser ablation resume, and lately the TPLA, transperineal interstitial laser ablation. The literature we are going to talk is a little bit scanty. The first clinical evidence in the treatment of BPH comes from Patelis, interventional radiologist who did a prospective, not randomized single center trial between 1914 and 1916 on 18 patients. They were surgical candidates. And the inclusion criteria were male above 50 years old with IFSS score above 13, a prostate volume above 30, a Qmax between 5 and 15, and a post-void residual above 50 cc. The exclusion criteria were urethral stricture, previous prostate or urethral surgery, prostate cancer, or neurological disorders. The primary endpoint was the technical success and safety of TPLA as the ability of completing the treatment. And there were several secondary endpoints as the operation time, ablation time, and energy delivered, hospitalization, catheterization time, and change in the IPSS, quality of life, Qmax, PVR, and prostatic volume at 3 months. In this first study, the patient was kept in the hospital for 2 days, and the catheter, in absence of adverse events, was removed after 2 weeks. So the study was a success. In fact, all procedures technically were all done correctly with good target and ablation of the both prostatic lobes. And you can see on the right on table 2 the details of the procedure, but the most important things were the significant improvements we have at 3 months with important percent change in the Qmax, 80%, and in the postcoital residual, 60%, in the IPSS, 47%, quality of life, 50%, and the reduction of the volume of 18%, all statistically significant. So finally, this first study was a complete technical success, was a short hospitalization. There was no need for recatheterization and no complication or side effect. 2 years later, in 2019, Pasella reported a multi-center trial as a retrospective, non-randomized, comes from 3 centers, so 160 patients with a follow-up of at least 6 months, and the cohort of 83 patients were after 12 months of follow-ups. 22% of patients were catheterized. Inclusion criteria was similar to the previous one, but interestingly, anticoagulant use and the indwelling urinary catheters were not excluded from the study. The results are really impressive. Even on the table 1, you have results after 6 months of follow-up, and on the right after 1 year of follow-up. And basically, the results are pretty similar. We have an improvement in the IPSS of 65%, in the PVR 75, up to 88 after 1 year, in the Qmax 87%, similar after 1 year, and quality of life improvement of 56%, and the volume reduction, very important, 27% at 6 months, up to 33% after 1 year. One of the drawbacks of the study that the ejaculatory function was not evaluated with a specific questionnaire, so probably there was an underestimation of the ejaculation disorder, and the erectile function was also not assessed. So Pasella concluded that the TPLA was a safe and effective procedure up to 12 months of follow-up. It was well tolerated without general anesthesia, low morbidity, and short hospitalization. In 2022, there was a study on prostate volume reduction done on beagle dogs in China. It comes out that after the procedure, the mean volume of the last laser ablated lesion increased within 1 month, then later on drops because of the inflammation and edema of the tissue. We know the beagle prostate is not like human prostate, but we can kind of assess it. This is very interesting, a photograph of the 3 zone that where we can see the lesion. The internal zone is the coagulated zone, and then with necrotic tissue. Then there is a marginal zone with many inflammatory cell infiltration, and then the peripheral zone untouched and untreated. So the prostate volume in clinical experience in human came from 19% on 3 months to 27% at 6, at 33 at 12 months. Quite kind of very good results. And then we give our the most recent studies. Our study represented on European urology. It was a way to give an objective way to treat this patient. It was a small cohort of 21 patients. Exclusion criteria was quite wide, 40 to 90 years old, IPSS score above 12, a prostate volume below 100. And the operative outcome was one I will show you. Operative time is like 36 minutes. Length of stay was, it was mostly outpatient procedure, 20 hours mean. Catheterization time was 8 days, and we use around 2 fibers. At 6 months, the improvements was quite impressive also in this third study. The Qmax improved by 50%, post-void residual by 95%, and the IPSS improved by 71%. And there was also an improvement in ejaculative function without any impact on erectile function. So if we look at the complication of this study, in the Pacella study, there was 3 grade 1 complications, 3 transient hematuria, 3 acute retention, resolved by catheter in 15 days, 1 orchitis, and 1 grade 3 complication was a prostatic abscess successfully drained. There was also 6 cases of transient dysuria and 2 cases of loss of ejaculative function. In our case, we have 1 abscess, and that was a patient had very severe dysuria. We transperineally we drain, and this is the video. I'll show you the procedure we did at the end. And after that, the patient was in very good condition and resolved all the symptoms. There is an ongoing study by in the Dutch study. It was supposed to come in the late 22, probably COVID delayed the results, but we know it's going to come out. So what are the advantages of TPLA? Already Luigi told us there is minimal invasiveness. There are small applicators. The transperineal route is safe, is already used for biopsy. There is no damage to the urethra, so no irritative symptoms and the risk of infection, no hematuria. You can do multiple applicators. You can do multiple ablation also to treat big prostate, also middle lobe. There is no need of blood transfusion. It's a very precise procedure. It's a very simple system of guidance. And you can do a real-time monitoring. So it's a safe energy delivery, and the area of ablation is predictable. So it's performed under conscious sedation with local anesthesia. So there is no need for general or epidural anesthesia. It is a good preservation, ejaculative function, no influence on erectile function, probably even improvement, because you have to discontinue 5 hours. The catheter is often removed after 1 or 2 days. If it still is the right time, is still under evaluation. So what are the pros? Short learning curve, good compliance by the patient, local anesthesia, feasible in outpatient setting, good preservation of erectile and ejaculative function, low risk of complication, a good balance between cost and effectiveness. I think there are also some cons. There is a need, already Pierluigi talked about the guidance system, so we have to drop this. What about infectious risks? We have to think about still. What is possible difficulties if there is a failure and the patient needs to go for BPH surgery? What are the results of duration? We know we only have 12 months of follow-up if there are long-term complications. I think it's an evolving, a very distinct procedures. And as it has been told before, the patient selection is paramount. So which are the patients who best suit these procedures? Moderate and severe LUTS, probably without the complication of BPH, and also in case of contraindication, inefficacy or complication of oral drugs, poor compliance for medication, or patient who will need to preserve ejaculation, young patient, or unfit for general spinal anesthesia. As a discussion, is really TPLA an alternative to surgical treatment or more to medical therapy in the future when we'll set better our procedure? And this has been shown already, and there is a registry for TPLA, come from the REIKE, the Dutch group, also other recruiting studies. So it's an evolving procedure, and in the next future we are going to see more data to set this procedure in the standard clinical practice. Thank you for your attention.
So thanks a lot, Professor Nitinol, for this very nice update on most recent results. Last presentation, which is SoracteLite clinical results from a single center prospective study, and is Dr. Giovanni Lunghesani. Thanks a lot for your participation. You can move to the presentation.
Okay, thanks a lot for the invitation. So I'll try to be very short, since I think we're running a little bit out of time, and I will present our experience with the SoracteLite treatment for BPH. So we already seen from the previous very nice presentations that when we're talking about treatment of BPH, we're talking about a galaxy of potential treatments. There are indeed some issues with current technologies because all of these technologies rely on surgeon's experience, and they all require urethral instrumentation, and they are likely to damage the ejaculatory ducts and to have a negative impact on the patient's sexual function. That's the reason why we have seen we are moving towards these minimally invasive surgical therapies. However, we must keep in mind that most of these attractive therapies need urethral instrumentations and potential complications related to this instrumentation. So we're talking about our experience. We performed this prospective observational study to assess the feasibility and efficacy of transperineal laser ablation in patients with BPH. These were our inclusion criteria. So basically patients with a small to medium-sized prostate and with a post-void residual of less than 200 millimeters, whereas patients with an history of bladder cancer or prostate cancer or with a previous urethral surgery were excluded. And I would like to show you a video showing a little bit of tips and tricks. So you already seen the machine, the EchoLaser X4, that has 4 independent laser sources and 4 flexible quartz optical fibers that can be used simultaneously to treat each lobe. Basically, this is a schematic view of the treatment. So we perform this treatment placing these fibers using a brachytherapy grid, because we believe that this can give you a little bit more of stability during the treatment. And as we already seen, the treatment causes a coagulative necrosis area. So the patient is placed under a lithotomy position. A catheter, a 3-way catheter, as shown by Professor Bove, is placed before the treatment with a continuous irrigation of saline solution. And then a perineal plane anesthesia is performed with lidocaine. Afterwards, the transrectal ultrasound probe is placed along with the brachytherapy grid, and an additional anesthesia is performed at the level of the apex of the prostate bilaterally in order to perform the entire procedure under local anesthesia. After that, we placed under ultrasound vision the 21 gauge introductor needle, and the treatment is planned keeping in mind to preserve all these distances that we already talked about. So 15 millimeters from the bladder neck and 1 centimeter approximately from the urethra and from the prostatic capsule. We try to place at least 1 fiber for each lobe and up to 2 fibers for each lobe, depending on the prostate size, and check the correct position both with a transversal and longitudinal view. And if a third lobe is present, we placed selectively a probe, also a needle, sorry, inside the lobe. Once we are ready for the treatment, the laser fiber is placed within the introducer needle, and it goes 1 centimeter outside of the needle, so you have to retract a little bit the introducer needle before starting the treatment, and then the EchoLaser smart interface can be used in order to plan the exact area that we are going to treat. After that, we perform the treatment using a 3 watt energy for at least 1,800 joule treatment for each lobe. During the ablation, you can clearly see some artifacts. So you can clearly see these hyperechoic areas coming on the screen that show you both in the longitudinal and transversal view that you are correctly treating the adenoma of the prostate. So this is the transversal view, and these show you basically the area, the coagulative necrosis area that you will achieve with the treatment. And then this was a controlled 1 month cystoscopy after the treatment, and you can clearly see the neocavity that was caused by the treatment, with obviously some fibrin inside, and the seminal caulicle is correctly preserved, as well as the external urinary sphincter. So going to the data, these are the demographic characteristics. So we can see that the prostate volume of our population was not that small, and that 5 of these patients had a third lobe. All of these patients were receiving a pharmacologic treatment. And these were the characteristics before surgery. So they were all patients with a very high IPSS and with a compromised quality of life. The ablation time was approximately 15 minutes, and the procedural time was approximately 45 minutes. 7 patients received a pullback. That means that the needle was taken out of approximately 1 centimeter, and a new treatment was performed, and this was done in case of large prostates. And the catheterization time was the median catheterization time was 7 days. And these are the results, the functional results that are in line with that shown by Professor Nitinol. So we can see that there is a clear improvement in all the parameters, flow parameters, and the IPSS. And more importantly, this difference is maintained and even more pronounced over time. Importantly, all of the sexually active patients maintain a good erectile function. The complication rate was quite low. We 2 patients actually require major antibiotics because of urinary tract infection. And there was just one patient experiencing an ejaculation, and that was related probably to the fact that the pullback was done in this case was a little bit too aggressive, and probably we did some damage on the seminal caulicle. So at the very end, we can conclude that TPLA may represent indeed a feasible and effective minimally invasive option, and represents indeed a true minimally invasive option with the advantage as compared to the other technologies to avoid the urethral instrumentation. So we would recommend this treatment in those patients with a small to medium sized prostate and that are strongly willing to preserve their ejaculation. As underscored by the previous speakers, indeed some comparative studies with standard BPH techniques are still needed before the implementation of this technique in the urologist armamentarium.
Oh, thanks a lot, Giovanni, for this very nice presentation, very complete, very exhaustive. Thanks a lot. My friend, Dr. Luca Cindolo, which is online and may start with his presentation. Thanks, Luca.
Thank you, Pierluigi. Thank you for this invitation. Also, thank you for this opportunity to the EchoLaser. This is one of the best topic I'm studying in the last few months.
You can move with the presentation.
Okay, thank you. This is a very interesting topic, the preservation of ejaculation, and this new technology, I think, can really help us as surgeon and all our patients in the management of BPO. The BPO is something very burden for the patient, but probably in our perspective, we have not this burden in our minds because we are prone to proceed with TURP or resection in case of obstruction and the impairment of bladder function. But in the science, in the literature, we are assisting to a really increase on the attention on the ejaculation disorders, as you can see in this slide. This is very recent research I've done, and this is an extraordinary way to explore the literature, showing us how the ejaculatory disorders are very hot topic. But from this is an interest from physiologists and also anatomists, and I'm asking you, are the ejaculation preserving techniques scientifically sound? And I will reply as soon as possible, yes. But considering the history of the ejaculation preserving technique during BPO relief, you can see here on the left of the screen how this interest has increased extraordinarily in the last years. Why this? Because a new technology has been introduced in our hands, in our market. So just now we have the opportunity to go deeper into this problem of the patient, and we can also appreciate how the literature has moved into the analysis of the patient's preferences. This is one of the paper I like more because this is a survey conducted in several European countries and also in the United States, showing how the patient underwent surgery, but also men candidated to BPH surgery, what they think about the maintenance and of erectile function and ejaculatory function. Of course, this is quite obvious that all men have interest in maintenance of ejaculatory function, but here there is a very good analysis on what the patient who lost ejaculation said about the loss of ejaculation. They at the beginning were well convinced and well trained to receive this alteration of the ejaculatory function, but after the procedure, they are quite disappointed about that. So the men candidated for BPH would like to receive something more gentle, less aggressive on their ejaculation. But if we ask the partners of these patients what they think about the ejaculation during sexual intercourse, so this is very important to share this knowledge that half of our partners consider very important that the man ejaculates during intercourse. Probably because the ejaculation, the expulsion of the sperm, is considered an expression of their sexual attractiveness, or probably they experience a more intensive orgasm depending on the intensity of their partner ejaculation. So the ejaculation that for a traditional urologist is something that can be lost after the prostatic surgery, to be honest, to be modern, is not. The partner, in fact, as already remembered, could be theoretically involved in the decision of the BPO surgical technique for the relief. So what we can offer, how we can move in this new galaxy, as Dr. Lugezzani said, how we can offer, we have, of course, monolateral TUEP, we have ejaculation sparing technique, we have aquablation and the others. But now we have transperineal laser ablation of the prostate. Why this is better, or this is probably better in the future? Because the ejaculation sparing techniques, taking together all the knowledge about the anatomical structure involved in the ejaculation and already remembered, are very fragile structures, and to be honest, are not so well known. So in my opinion, one of the best ideas is, please, if possible, don't touch this triangle. Okay, we can spare some tissue, we can touch the blood neck, we can spare the ejaculatory duct, but if possible, because we don't know exactly where are, what they work, please, if possible, don't touch it. This is the real, the only way to avoid to maneuver and to impact on this structure are, to be honest, this laser or the embolization. Of course, the balance between minimal invasive or micro-invasive surgical technique and surgery should be balanced between the need of the patient. If we need tissue debulking, durability, and greater symptoms control, so we move towards surgery. But more and more every day in our consultation, we see patients asking for office-based technique, ejaculation preservative techniques. And I had a lot of papers and meta-analysis in the literature I read just recently and also reviewed that highlight how the literature is so heterogeneous and also sparse. The results on sexual function has been reported as ancillary endpoints and not primary endpoints. So we have some systematic and narrative reviews of high quality, but the study involved in this paper are normally of low quality. So in the future, we need prospective and projected study, especially investigating the multi-dimension field of ejaculation. And this is what Professor Bove is doing, because in the clinicaltrial.gov we can see how this technology will be studied in his center. And we have to consider to take in our minds that the novel techniques, of course, should be better investigated, not only on the short term, but also on long-term effects. Of course, we have to repeat to ourselves that a patient-centered care is something difficult, time-consuming, and also requiring new capability of urologists. As urologists, in fact, I think we have to learn on how manage this counseling that could be long, time-consuming, and also difficult. Of course, we have to consider that the maintenance of erections and ejaculatory function is very important for the patient perspective and from his partner perspective. So now we have, in conclusion, two news. One bad news and one good news. The bad news is that now we have a choice. We have a galaxy of surgical techniques, but we have also a good news. We have a choice. So when we have to select the patient, the technique, considering prostate volume and patient expectations, probably we can also have more difficulty, and we have to face not only the patient, but we have to learn on how to manage the clinical counseling during the consultation. So I repeat, we have to think to micro-invasive procedure for patients who prefer office-based procedure and preservation of ejaculation. So all the techniques we had in this afternoon are innovative, safe. Not all the studies, not all the techniques has a long history, but we have to also take into account the novelty, and we have to look with a great attention, especially to this TPLA, that probably in the future, sparing an approach through a transurethral approach could be very interesting. Of course, we have to highlight has the long-term research and results still needed, especially of high quality, as Professor Bove and his team are doing. So difference in terms of patients and partner expectation, this will be proper selection of technique, and we have to master different technique, and we can propose different options. In case we don't master, for example, TPLA, because we are not familiar with transperineal approach. We never done brachytherapy, never done cryotherapy. Consider to the referral of patients, in my mind, is one of the best solutions to ensure for the patients the highest quality of health care. Thank you, Professor Bove.
Luca, thanks a lot for this very, very nice presentation and all the suggestions about that today it is possible to spare the ejaculation, and hopefully this is going to be, you know, the real message. We today have the possibility to give this opportunity to more and more patients every day. So I like to keep in mind your good news that you gave us. And so I want to thank everybody, but first of all, if there is still the audience and you are available, we have some questions from the audience. So if you are so kind to answer, the first question is if we can briefly give some idea about costs. This is one of the first questions that has been asked. So I can answer for TPLA, but you know, the answer is that we don't have a definitive answer about costs, because it depends on the plan that you want to do with your hospital and how many procedures you want to perform per year. So basically it depends. I cannot give you costs. I can basically tell you that we have to consider that this kind of technology about the patient to be treated in very few minutes. And so the time that you keep the patient in the operating room is very short, and you can perform the patient on outpatient basis. So in regard of the reimbursement from the government, we are still fighting, because it depends on the region, and it depends on the ASL, so the unit that give us the codes to have reimbursement from the region. So we are still fighting about it. But as regard the cost, I prefer to have a single talk with the representative that can give you an idea about the tailored cost for your unit. If you can answer briefly with for a resume and TPLA, for example, Dr. Galfano, Dottoressa Silvia Secco. If you can give us an idea about costs.
Yeah, okay. Sorry, I'm here. I can also answer on behalf of Dr. Galfano regarding the PLA, the PAE. Yes. It's actually reimbursed by our regional system. It costs around 1,500 euros for each case. And regarding Eurolift, for each device we implant in the patient is around 500 or 600 euros for each implant. So it depends on prostate size.
Okay. So and basically you take in place 2, is that right?
Or 4 is better.
4 is better. So the cost, the final cost is around 2,000 euros.
Yeah, yes, of course, and it strictly depends on prostatic shape and volume. Yes.
Okay. You also have, sorry, an idea about PAE, isn't it?
Yes, around 1,500 euros for each case. Yes.
Okay. So can somebody give us an idea about resume?
This is Dr. Talle speaking.
Yes.
Well, actually, I don't know exactly the cost of the procedure. What I know is that there are all disposable devices what we use in Resume. What I can tell you is that when a patient's in our hospital decided the private form, the cost is about 5,000 euros. That's what I know.
5,000 euros for each procedure?
Yes, that's what the patients.
Wow, it's a lot. So I can definitely say that maybe, you know, the SoracteLite is the, you know, it's very cheap in regards to these procedures. So I cannot give you exactly an idea, but, you know, we use about 2 fibers, and I don't want to give you cost because it may vary a lot if you take, if you use 2 or 4 fibers, but mainly you can perform the procedures with 2 fibers, and the cost is much less than what I heard today. So we can move to another question. And one question is if they had some experience of urolift migration after Resume treatment.
No, we don't.
Experience?
No, we don't. We don't.
No,
we
experience.
have a short experience. I would say a short experience. So actually, so far we don't have such experience. No.
And another question is maybe for Professor Nitinol. Can you tell us something about PSA and TPLA? How do the PSA move after the procedure?
Okay. Yes, we test the PSA after a couple of weeks from the procedure. There was an increase in the PSA, but at 3 months, we go back to baseline and below the baseline. So it can be kind of a parameter to check for prostate volume also. And it follows exactly what happened when you have prostate inflammation, prostatitis, and you have an increase in PSA, and then it falls down. If we can give you a word on the cost, as you told you before, I know that there is no a clear cost for the for any of these new procedures, but as you know, a sensational rule of thumb, I think that the TPLA looks the cheapest one between all the procedure, just in terms of materials and machine we are going to use.
Yes, I agree, definitely. Okay, so we have still a lot of questions, but I think that the time's run. So we are at the end of the webinar, and I want to thanks again all the participants and all the speakers. Thanks a lot to Elesta, who gave us this nice opportunity, and hope to see all you very soon in the next conference, hopefully at the end of this crazy time. Okay, thanks a lot to everybody.